Hello, I'm Eric Strong from Strong Medicine, and today I'm discussing the BRASH syndrome. This unusual sounding name for a medical condition is an acronym that lists its key features: bradycardia, renal failure, AV nodal blockade, shock, and hyperkalemia. How does BRASH clinically present? Presentations are variable, ranging from asymptomatic lab abnormalities to shock and multi-organ failure. The typical patient is elderly, on one or more cardiovascular meds, particularly antihypertensives, who becomes dehydrated. The typical admission potassium level is in the range of 6.0 to 7.5 milliequivalents per liter, so high, but not astronomically so. However, classic ECG findings of hyperkalemia, such as peak T waves and wide QRS complexes, may be absent. In other words, the bradycardia seen is out of proportion to the other ECG findings typical of hyperkalemia. Here's what a typical ECG might look like in BRASH syndrome. Obviously, it's very slow, with a heart rate in this particular example of about 30 beats per minute. There are some peaked T waves, but they aren't the most extremely peaked Ts ever. And the P waves have been flattened, but it's lacking the QRS widening and unusual QRS morphology that would suggest severe hyperkalemia. The pathogenesis of BRASH directly explains its manifestations, so it warrants some discussion. In short, BRASH is due to a positive feedback loop in which renal failure leads to hyperkalemia, hyperkalemia leads to bradycardia, bradycardia leads to hypotension, and hypotension worsens the renal failure. In addition, when patients are on meds which either inhibit the sinus and/or AV nodes, they contribute to the bradycardia, and depending on mechanism, may contribute directly to the hypotension as well. This is particularly prominent when the med in question is usually excreted by the kidneys, such as atenolol. As the kidneys fail, the medication builds up to toxic levels, increasing the effect of the blockade. The synergy between hyperkalemia and AV and sinus node blockade on heart rate is the critical defining feature of BRASH. In other words, patients are more bradycardic than you would expect from either the hyperkalemia or the medication effect alone. And as the cycle progresses, eventually shock and multi-organ failure can follow. Looking at this diagram, we can also speculate as to the common triggers for BRASH. For example, any cause of hypotension can trigger the feedback loop, most commonly dehydration or sepsis. Nephrotoxins can trigger the loop by inducing renal failure, and medication toxicity can trigger the loop by causing renal failure, nodal blockade, or hyperkalemia. When looking at published case reports of BRASH, the most implicated meds appear to be the non-dihydropyridine calcium channel blockers, such as verapamil and diltiazem, the beta blockers metoprolol and carvedilol, and the potassium-sparing diuretic spironolactone. However, ACE inhibitors, ARBs, digoxin, sotalol, amiodarone, and eplerenone can all trigger it as well. Importantly, the initial trigger for the syndrome can be clinically milder than the syndrome itself. For example, some dehydration from a mild heat exhaustion or gastroenteritis, which otherwise might have been self-limited and fully resolved within 1 to 2 days, could potentially trigger a pathophysiologic cascade leading to shock in patients predisposed due to their medication use or chronic kidney disease. When it comes to diagnosis, BRASH is a purely clinical diagnosis and usually not a difficult one to make, provided you are aware of the syndrome. When it comes to the differential diagnosis of BRASH, the most important distinction to make is whether the presentation is primarily due to hyperkalemia alone, whether it's primarily due to the SA and AV nodal blockade alone, or whether the patient is experiencing a synergy of the two. When hyperkalemia is driving the clinical presentation, the potassium is usually above 7.5 and almost always above 7.0. When nodal blockade is driving the presentation, it is almost always related to a recently started medication or an increase in the dose of a prior med. It could also be from a new med-med interaction, and the potassium is usually normal. But when it's truly the synergy between the two, hyperkalemia is present but relatively modest, and the ECG changes of hyperkalemia are relatively minor. Regarding treatment, the most important immediate step is addressing the hyperkalemia. While in my experience, many physicians and clinicians are excessively aggressive with treating hyperkalemia in general, for example, giving calcium to anyone whose K is outside the normal range, even a little bit, absence of ECG findings notwithstanding. But BRASH syndrome specifically is one situation in which you really do want to err on the side of the hyperkalemia kitchen sink, particularly IV calcium. Other options which act within minutes include insulin, which should be paired with dextrose to prevent hypoglycemia, and nebulized albuterol. While those provide just temporary benefits, reversing the bradycardia and hypotension may restore renal perfusion enough to begin excreting the body's excess potassium. One can consider an infusion of epinephrine, which has the combined benefit of directly increasing the heart rate while driving potassium into cells. If the patient is hypovolemic, of course give IV fluids. So-called balanced fluids, such as lactated ringers and normal sol, are counterintuitively better than normal saline despite containing small amounts of potassium. This is because the quantity of potassium they contain is relatively small, and because normal saline can induce a metabolic acidosis, which results in a transcellular shift of potassium in the wrong direction. And if the patient is on a calcium channel blocker, beta blocker, or digoxin, consider a reversal strategy in consultation with a toxicologist if one is available, or a pharmacist if one is not. With prompt recognition, hemodialysis and transcutaneous pacing can usually be avoided. Regarding prognosis, with appropriate treatment, most patients experience a rapid and full recovery.